This presentation is going to be on muscarinic agonists. Because these are muscarinic agonists, these are going to be the cholinergic drugs that fall within this, okay? So they're promoting or influencing the activity of cholinergic receptors because they're agonists. And most of these drugs act directly on that cholinergic receptor by either mimicking or blocking the actions of acetylcholine. But we also have the cholinesterase inhibitors. They also activate the cholinergic receptors, but they do this indirectly by preventing the breakdown of acetylcholine. Cholinergic drugs have therapeutic benefits, which we love, but they also have toxic benefits as well, toxic significance, and we need to be aware of those things. Now, therapeutically, there's not a lot of things that we can really use it for. However, the toxicology of cholinergic drugs is pretty extensive. This encompasses things like nicotine, insecticides, and drug compounds that were designed for chemical warfare. The 6 categories of cholinergic drugs include the muscarinic agonist, muscarinic antagonists, the cholinesterase inhibitors, ganglionic stimulating agents, ganglionic blocking agents, and the neuromuscular blocking agents. Now, the muscarinic antagonists we are going to talk more about in the next presentation. And the ganglionic blocking agents and neuromuscular agents, we'll touch upon these, but really these are going to be things that would be preserved for specialists. Going back to the muscarinic agonists, remembering again, they're going to selectively mimic the effects of acetylcholine at the muscarinic receptor. The inhibitors, the cholinesterase inhibitors, they're preventing the breakdown of acetylcholine by acetylcholinesterase. Remember that difference. So the result is more acetylcholine remains available to activate the cholinergic receptors. Okay, so that's going to be the net result for both of these actions. There is an example, bethanechol. And bethanechol is a selective antagonist at the muscarinic cholinergic receptor. And we see that activation of this muscarinic receptor can produce the following effects. We will have things like ocular effects, miosis, ciliary muscular contraction. We might have slowing of the heart rate, bronchial constriction, urination, glandular secretion, stimulation of the GI tract, and vasodilation. And because bethanechol activates these muscarinic receptors, the drug is capable of eliciting all these responses because they're activating the receptors that cause these effects. So if you know which receptors bethanechol activates, then you can know what to expect if you prescribe this to your patient. And you can predict the kinds of responses that you would expect bethanechol to then produce. Again, bethanechol is a muscarinic agonist. Okay, so it's binding to that muscarinic receptor, causing receptor activation, and most of all the muscarinic receptors are associated with the parasympathetic nervous system. And so the responses to the muscarinic agonist will really resemble the production and the stimulation of parasympathetic nerves. So sometimes they're called parasympathomimetic agents because they're mimicking the parasympathetic nervous system nerve activation. Okay. So we're going to talk about bethanechol in a little bit more detail now. This really does provide the prototype or embodies the typical characteristics of all the muscarinic agonists, and so we will use this as a prototype. This is the drug that I want you to know under this level or under this muscarinic agonists. So, the mechanism of action, it is a direct acting muscarinic agent. Know that it's directly acting on the muscarinic receptor. It's going to bind reversibly to the muscarinic cholinergic receptor to cause activation. If we prescribe it at therapeutic doses, it acts selectively on the receptor, and it has little or no effect on the nicotinic receptors, the ganglionic receptors, or the skeletal muscle. What we're trying to elicit is a response typical of muscarinic receptor activation. So if we know what happens when we activate the muscarinic receptors, and we know what bothanicol will do. The principal structures that affect muscarinic activation of the heart: exocrine glands, smooth muscles, and the eyes. So when the muscarinic agonist acts on the heart, it will cause a decrease in heart rate or bradycardia. When it's acting upon the exocrine glands, it's going to increase your patient's salivation, their sweating, may increase bronchial secretions and gastric secretions as well, gastric acid. In the smooth muscles of the lungs and the GI tract, the muscarinic agonist will promote contraction. The result is going to be the constriction of bronchi, increased tone, and the mobility of GI smooth muscle. In the bladder, muscarinic activation will cause contraction of the detrusor muscle and relaxation of the trigone and the sphincter. And what this will do is help with the bladder to empty better. And vascular smooth muscles, they're going to cause relaxation. So the result of that is vasodilation, which then subsequently can produce hypotension. Now, activation of the muscarinic receptors in the eyes, it has two effects. We have pupillary constriction or miosis, and then the contraction of the ciliary muscle. When this happens, it results in accommodation for near vision. So that ciliary muscle, it's attached to the lens, and this is what helps us to focus our eyes for near vision. It will alter that lens curvature to help us to accommodate for near vision. The pharmacokinetics of bothanicol, in terms of administration, it is an oral preparation, and you will start to see the effects within 30 to 60 minutes, and it will persist for about an hour from the time your patient gets a maximal effect. As a result of the pharmacokinetics of this drug, only a small fraction of every dose will actually be absorbed. And it has to do with how this drug carries a positive charge and it crosses membranes poorly. In theory, bothanicol can produce a full range of muscarinic responses as side effects. With oral dosing, however, it's very rare that you would encompass these side effects. But again, if you do, the things to look for are, again, the hypertension that can happen with the cardiovascular system, that's secondary to vasodilation and bradycardia. We might even have lower cardiac output, low blood pressure, right? That will be in result of the cardiovascular system reactions. In the GI, at therapeutic doses, it can cause excessive salivation, excessive secretion of gastric acid. Because it also can cause some contraction, your patient may complain of abdominal cramps, diarrhea. Higher doses can cause involuntary defecation. So make sure you are aware of that side effect. It's also contraindicated for patients that already have a gastric ulcer, because that stimulation of acid secretion is just going to intensify and put them at risk for more gastric erosion, and also will increase the risk for bleeding. What you don't want to do is perforate your patient's GI system or perforate the bowel. It's also contraindicated for patients with intestinal obstruction for obvious reasons, right? And anyone that's recovering from recent surgery of the bowel. The ability for Bethanical to increase the tone and mobility of the intestinal smooth muscle can actually result in rupture of that bowel wall. In terms of the urinary tract, because its ability to contract the bladder detrusor and increase the pressure within the urinary tract, it can be hazardous for patients that have a urinary tract obstruction or they have an overall weak bladder wall. Elevation of this pressure in the urinary tract can rupture the bladder. So you have to think about that in terms of whether you want to use this drug for someone that's having difficulty emptying or not. What is the status of their bladder wall? And is there an already underlying obstruction that you're worried about? Bethanical can also exacerbate asthma because it's activating the muscarinic receptors of the lungs. It can cause bronchoconstriction. Dysrhythmias in patients that have hyperthyroidism. So Bethanical is contraindicated for people with hypothyroidism. Okay, so anyone with hyperthyroidism, if it's given to a patient, it can actually increase the heart rate to the point of initiating a dysrhythmia. Okay, so again, hyperthyroidism, so high thyroid production or thyroid gland overproduction can be a source of contraindication causing dysrhythmia. No Bethanical for hyperthyroidism. Why? Well, that initial cardiovascular response is going to be like everyone else. It's first going to start with bradycardia and hypotension. But in reaction to hypotension, you have your baroreceptor reflex. It's going to attempt to return blood pressure to normal, right? To put back the body into equilibrium. Well, part of this reflex involves the release of norepinephrine from the sympathetic nerve that regulates your heart. So with patients that have hyperthyroidism, norepinephrine release can increase cardiac output and helps restore blood pressure. It's a good thing, right? But in patients, norepinephrine can actually induce cardiac dysrhythmias. The reason for this is kind of an unusual response in patients with hyperthyroidism. So if they don't have hyperthyroidism, that norepinephrine release is good. It's going to bring you back to whole or where your blood pressure should be. But when you have hyperthyroidism, the heart is going to be extra sensitive to the effects of norepinephrine. So even the smallest amounts can stimulate a significant toxic effect and elicit a dysrhythmia. Cevimeline is another type of muscarinic agonist or cholinergic drug, and it's a derivative of acetylcholine, so the action is going to be very close to Bethanical, but we use it for different reasons. It's indicated for the relief of dry mouth or xerostomia, and we use it in patients with Sjogren's syndrome, which is an autoimmune disease that causes xerostomia. Now, it seems like it might not be that big a deal to have dry mouth, but it can lead to multiple complications like periodontal disease. You can have increased dental caries. So you're more at risk for having cavities. It does alter your taste. It does put you at risk for oral ulcers, candidiasis, and it does make eating and speaking very difficult to not have enough saliva production. So by giving this medication, we can relieve dry mouth because it's activating the muscarinic receptors on the residual healthy tissue that's left in your salivary glands, and it's going to promote increased salivation. When it's stimulating the salivation, your patients can, start to have lower risk for, again, periodontal disease, dental caries, altered tastes, ulcers, etc. Well, because we know that it can help produce salivation, sometimes it is being used to help with dry mouth that's caused by radiation therapy of the head and neck cancers. And even though it's not been FDA approved for this use, providers will use it for that reason. And it also can be used to help manage inflammation of the cornea and conjunctiva. And this is called keratoconjunctivitis sicca. And it will increase tear production and relieve that discomfort that's associated with conditions that cause dry eye. Okay, because again, it's trying to stimulate more fluid. So there are some adverse effects, and these are very similar to bethanechol. The most common is for this drug, it's excessive sweating, nausea, rhinitis, and diarrhea. When patients are on cevimeline, they are at an increased risk for UTIs. And to compensate for fluid loss that's caused by the sweating and diarrhea, you should increase your patient's fluid intake. Just like bethanechol, cevimeline can also promote miosis, so that constriction of the pupil, and this may cause blurred vision and a loss of visual acuity. So especially at night, you want to make sure your patients are safe and they are not driving when they're experiencing miosis. Activation of cardiac muscarinic receptors reduce heart rate, slow cardiac conduction, and therefore you want to make sure that you are screening for patients with a history of heart disease and use it cautiously or not at all. Also, because we know that muscarinic activation increases airway resistance, it is contraindicated for patients with uncontrolled asthma. Shouldn't be used for patients. Well, you want to be very careful if you're going to use it with patients, even if they have controlled asthma, chronic bronchitis, or any type of chronic obstructive pulmonary disease like emphysema as well. It's contraindicated, absolutely contraindicated for people with narrow angle glaucoma and iritis. Pilocarpine is also a muscarinic agonist or cholinergic drug, and we use it topically for glaucoma. Glaucoma, remembering that this is an eye disorder that is characterized by increased or elevated intraocular pressure. And so with this, you're going to have injury to the optic nerve. In addition to using this for glaucoma, there is an oral pilocarpine that's approved for dry mouth as well in result of Sjogren's syndrome, so very similar to the last drug that we talked about, and it also can be used for radiation therapy of the head and neck cancers, causing a decrease in saliva due to salivary gland damage. When it's used for that reason, it's actually going to be found under a different trade name, Salagen, Salagen, and it can be given to the patients to manage dry mouth that's secondary to these head and neck cancers. Now, it's been approved for this specifically, where the other drug was not approved for it, but can be used for it. Now, at lower doses, the adverse effect for this drug, the most common is sweating. But if dosage is excessive, it can actually produce that full spectrum of muscarinic effects that we've talked about previously. You can see here the tables showing the preparations and dosages that are available and the pharmacokinetics of muscarinic agonists. With bethanechol, we do have a peak of 1 to 1.5 hours, a little bit shorter than cevimeline, and we do have metabolism of bethanechol and elimination of bethanechol that is unknown. It does have a half-life of 2 hours. With cevimeline, we have a peak of 1.5 to 2 hours. It is mainly hepatic metabolism with the CYP enzymes, and the elimination is majority in urine, and the remaining elimination occurs through the feces. The half-life is 4 to 6 hours. With pilocarpine, under all trainings, you can see that the peak for ophthalmic dosage is 0.5 to 1 hour. And it is also hepatic metabolism eliminated in the urine, and it has a half-life of 1 to 1.5 hours. Bethanechol is a PO preparation as well as cevimeline. Remembering then that pilocarpine is coming in ophthalmic preparation, so there's solutions and there's gel, and if it is in that other trade name Salagen, that's used for the dry mouth associated with Sjogren's syndrome or radiation therapy for cancer, it does come in a PO form. Pyridostigmine is our prototype drug for the reversible cholinesterase inhibitors. Okay, so this is another subgroup of muscarinic agonists, and they prevent the degradation of acetylcholine by acetylcholinesterase. So sometimes they're called anti-cholinesterase drugs. And if you're able to break down acetylcholine, then those cholinesterase inhibitors will increase the amount of acetylcholine that's available to activate receptors. So we're enhancing cholinergic actions. Because they don't directly bind to cholinergic receptors, we view them as indirect acting cholinergic agents. And by using them, we are going to inhibit the results in transmission at the cholinergic junctions, so all of them, the muscarinic, ganglionic, and the neuromuscular. So it does have a inability for selectivity. It doesn't select any of those things, so you're going to have a broad spectrum of responses, but that's why it is very limited on the therapeutic applications. It lacks selectivity. So we use it mainly for the treatment of myasthenia gravis, but it can also be used for glaucoma, Alzheimer's, and Parkinson's disease dementia. It can also be used if a patient was given a muscarinic antagonist and is having toxicity from it. It can help to reverse that by giving a muscarinic agonist. So again, pyridostigmine, this is going to be our prototype drug, and it is the drug of choice for the management of myasthenia gravis. Because it carries a positive charge, it can't readily cross the membranes like our GI tract, blood-brain barrier, and our placenta, so it's absorbed poorly after PO administration and has minimal effects on on our brain and on the fetus. The adverse effects that you're looking for, two things. You're going to look for excessive muscarinic stimulation and neuromuscular blockade. So with excessive muscarinic stimulation, there's accumulation of acetylcholine that occurs at the muscarinic receptor. So this can result in excessive salivation, increased gastric secretions, increased tone and motility of the GI tract. It can make your patient feel like they need to urinate all the time, so urinating and having that with urgency. So urinary urgency, bradycardia, sweating, meiosis, and they can also have issues with accommodation causing spasms, so they're having problems with focusing for near vision. If these responses are occurring, it may be necessary to use atropine to reverse these muscarinic responses. In terms of the neuromuscular blockade, if it's given in toxic doses, it can cause accumulation of acetylcholine in amounts that are sufficient enough to produce a depolarizing neuromuscular blockade. And it can cause paralysis of the respiratory muscles, which would be the fatal thing that could happen in terms of this adverse effect of neuromuscular blockade. Now we are going to talk about irreversible cholinesterase inhibitors. There's only one that is used for glaucoma treatment, and it's called ecothiopate. The mechanism of action is it binds to the active center of cholinesterase, and it's going to prevent the enzyme from hydrolyzing that acetylcholine. It is only one drug, again, that falls under the irreversible cholinesterase inhibitors. And it contains an atom of phosphorus, and because of this, the irreversible inhibitors are known to organophosphate cholinesterase inhibitors. Sometimes that's what they're called, but I won't be spending too much time belaboring that detail. Now, almost all of the irreversible cholinesterase inhibitors are highly lipid soluble, and as a result, they're absorbed from all routes of administration, and they can be absorbed directly through the skin. So it's you want to be careful because it can be highly toxic if it moves through the skin, and that's not what you want to happen. And it does make these types of agents good insecticides. It gives them the potential also to be used for chemical warfare because they're easily absorbed, and they can have access to all your tissues and your organs, including your CNS. So, the mechanism of action is to bind to the active center of cholinesterase, which we just said it prevents that enzyme from hydrolyzing acetylcholine, and it will, even though it's going to split from cholinesterase, that reaction is going to be so slow, and under normal conditions, the binding to cholinesterase can be considered irreversible. Because it's irreversible, effects will persist until those new molecules of cholinesterase can be synthesized. So it does take a very long time. So we just call them irreversible because it would take too long for that reaction to happen. And although we can consider the bond between irreversible inhibitors and cholinesterase permanent, it can be broken. But to break that bond, to reverse the inhibition of cholinesterase, you have to administer pralidoxime, which is a cholinase or cholinesterase reactivator. And that's the only thing that you can use for that purpose. This is a table showing you the clinical applications of cholinesterase inhibitors. And we just finished talking about the prototype of reversible inhibitors, which is pyridostigmine. And you can see that it is in a PO dose. It treats myasthenia gravis, and it can also be used as a reversal competitive musculoskeletal blockade agent. Another drug that can do that same thing for the neuromuscular blockade is prostigmine, which is the first one on that list as well. But pay attention to pyridostigmine because it is a prototype, but another one to just look out for because it is commonly used is donepezil, which is Aricept, and it is a PO drug, and we use it for Alzheimer's. The majority of these are going to be either used for Alzheimer's, which are those last three in the reversible inhibitors, or we do have the top two that treat for myasthenia gravis. We also have the one that we talked about that treats for glaucoma, and this is an irreversible inhibitor, phospholine iodine, and it is a topical agent, unlike the PO versions. This chart summarizes the pharmacokinetics of cholinesterase inhibitors, and you can see with the pyridostigmine that the peak is 1 to 2 hours, very similar to neostigmine as well, which is another cholinesterase inhibitors. But unlike neostigmine, pyridostigmine metabolizes through the hydrolysis by the cholinesterase, which is the same as the visvostigmine as well. They're very similar half-lives, and they're all eliminated by urine. The preparation and doses of cholinesterase inhibitors are in the second table here, and we will focus on our prototype, which is the pyridostigmine on the bottom. It does come in a syrup and tablets, extended release and intermittent release. Obviously, with myasthenia gravis treatment, because of their difficulties in swallowing, sometimes the syrup is indicated, and so you can see that it is available in a suspension of 60 milligrams over 5 milliliters. I do want to point towards visvostigmine for just a second. It falls under the cholinesterase inhibitor classification, and this can be used as a reversal of an anticholinergic toxicity that occurs, and we would dose it at about 0.5 to 2 milligrams IM or an IV administration can be used, and you can use it every 10 to 30 minutes as needed to reverse the anticholinergic toxicity. Neostigmine can be used to reverse the effects of the non-depolarizing neuromuscular blocking agents that can occur after surgery, but it is also, just like pyridostigmine, can be used for myasthenia gravis as well. I just want to share a little bit more detail now about myasthenia gravis so you can understand better myasthenic crisis and cholinergic crisis, which you need to be able to differentiate because if you find your patient in one of these crises, then the treatment is different. So first, the pathophysiology of myasthenia gravis. Knowing again, we do use pyridostigmine, right, as the drug of choice to treat this. And what we're trying to do is help with the muscle weakness. Myasthenia gravis is characterized by fluctuating muscle weakness and then having a predisposition to rapid fatigue afterwards. And the common symptoms include ptosis, or that drooping eyelid, difficulty swallowing, and you're going to have overall weakness of the skeletal muscles, which will include the muscles of respiration. And this is why your patient will have difficulty breathing most often with myasthenia gravis, especially as the disease process worsens. Now, the symptoms of myasthenia gravis is the result from an autoimmune process where your body is producing antibodies that are attacking the nicotinic M receptors on the skeletal muscle. And as a result, the functional receptors at the neuromuscular junction are being reduced to even up to about 90%. So then you're only left with between 10 to 30% of functional receptors at the neuromuscular junction. Because of this lack of functional receptors at the neuromuscular junction, then the patient experiences muscle weakness. So when a patient is in a myasthenic crisis, and this can be due to not being, properly or inadequately medicated on pyridostigmine, they will be in an excessive, extreme state of muscle weakness, and therefore they will be in either paralysis of the muscles of respiration, and it can actually result in death because of the paralysis of muscle respiration. And you can give a cholinesterase inhibitor like neostigmine to help to relieve the crisis. Okay, so you're trying to up the cholinesterase inhibitor to take away this extreme muscle weakness that was caused by insufficient acetylcholine at that neuromuscular junction. But with a cholinergic crisis, this is usually going to be caused when there's an overdose of cholinesterase inhibitors. And like a myasthenic crisis, you're going to see extreme muscle weakness and frank paralysis. But what you need to do to treat someone in a cholinergic crisis is to provide atropine and respiratory support. And then, of course, you want to stop the use of the cholinesterase inhibitor that put them in this cholinergic crisis in the first place. And because myasthenic crisis and cholinergic crisis, they are very similar in terms of their symptoms, the muscle weakness and paralysis, sometimes it's hard to distinguish, but because they're treated very differently, we need to know which one our patient is in. And so sometimes knowing the history of the medication or the signs and symptoms of excessive muscarinic stimulation can help, but it doesn't still delineate the difference between the two. So there is a controversial method that can be used, and it's by providing a challenge dose of idurofonium, which is idofonium. It's an ultra short acting cholinesterase inhibitor, so it works really fast. And when you give idurofonium and it induces an elevation of acetylcholine, it will alleviate the symptoms if your patient is in a myasthenic crisis. If they're not in a myasthenic crisis, if you're giving this drug, idurofonium, it can actually be life-threatening because it's making the symptoms of cholinergic crisis worse. So you might be able to have identified if it was myasthenic or cholinergic, but if it was cholinergic, you just made things worse, and that's why it's so controversial to use. So again, if it's cholinergic crisis, atropine and oxygen, those are the immediate antidotes for a cholinergic crisis, or that's the treatment that you need to do to reverse this cholinergic crisis. So if you are going to try this, which you wouldn't do in primary care. And if a patient is going to be challenged with edrophonium, then you have to have atropine and oxygen ready to go just in case it was a cholinergic crisis and not a myasthenic crisis.